Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Zachary Schwartz. In this episode, we explore the potential role of ART in weight change among people living with HIV. We're joined by expert faculty, Dr. Cristina Mussini from University of Modena School of Medicine in Italy, and Dr. William Short from the Perelman School of Medicine at University of Pennsylvania. Today, they'll discuss whether an ART switch can lead to late loss after weight gain and how to counsel people living with HIV on weight loss options. To follow along with the slides, please see the link in the show notes. And to get access to all of our podcasts, you can subscribe to the CCO Infectious Disease podcast on your favorite podcast player. So now let's get started and join our faculty as they discuss this important issue using a case.
So let's start with our case. We are talking about a 37-year-old cisgender woman who was starting in bictegravir, FTC, and TAF 2 years ago. She has experienced a 6-kilogram weight gain that she attributes to her heart. So she has just hypertension as comorbidity. You see her immunological situation is very good, and as her viral load is undetectable, she has no hepatitis B or C co-infection, and also the lipid profile with the cholesterol is very good, and her BMI is 28. So when we talk about weight gain, we should not forget the impact of this on people living with HIV. We know that also in the general population, but especially in people living with HIV, the proportion of overweight, let's say a BMI between 25 and 29.9, and obese with a BMI higher than 30 kilogram per square meter, in people living with HIV has increased globally. Obesity contributes to adverse health outcomes such as cardiovascular disease, type 2 diabetes mellitus, and hypertension. Particularly women living with HIV have higher risk of cardiometabolic disease, including sudden cardiac death, acute myocardial infarction, and subclinical carotid arteriosclerosis.
So a common question we all have is, what role does antiretroviral therapy play in weight gain for people living with HIV? It's a common question we all ask all the time, every time we see patients. So I think there's been really an increase in the data points that we've seen that I'm hopefully going to share with you in the next couple slides. So first, let's look. This is a classic study that has been around for a while now, led by Paul Sachs, and it was a multivariate analysis of weight gain after antiretroviral start. And they looked at 8 phase 3 randomized trials of first-line ART during the period of 2003 to 2015. And you can see a very large sample size of over 5,000 patients. These were INSTI-containing regimen versus PI versus NNRTI. And what we saw here is that INSTI-containing regimens were associated with more weight gain than NNRTI or PI-based regimen. And if you look at the 3 graphs to the left, you see that. So there's your INSTI on the left in red. Again, looking at, here we use least square means weight change. And again, that INSTI in red sort of stands out. When you look at the individual INSTIs, what we see is that bictegravir and dolutegravir seem to overlap, and much less with sort of the first generation elvitegravir that's boosted with COBI. And then what about the role of the nucleoside reverse transcriptase inhibitors? And what we see there clearly is TAF stands out, and then you sort of go down with abacavir, tenofovir disoproxil, and then zidovudine. What are the factors, though? So what are the factors that came out of this analysis that were associated with weight gain? Well, one, having a lower CD4 count and having a higher HIV RNA level. No intravenous drug use, female sex, Black race, those who had symptomatic HIV, and younger age. And here we define younger as less than 50 years, and those with higher BMIs. So this sort of sets the standard for what we've been seeing and what we've seen with associations. So we look at influences of weight gain with treatment. So you look at what are the things that are enhancing, that help to promote weight gain, or attenuating. And then what are the things that are neutral? So if you look on the left, what are the host factors? So having a high pretreatment viral load, low pretreatment CD4 count, female sex, Black race, those who are underweight at initiation of antiretroviral therapy, and then host genetics and pharmacogenetics. I think we all know that. What are some of the things that attenuate? These are opportunistic conditions. We know that. We know people who present with opportunistic infections sometimes appear very emaciated. So they sort of stand out. And then substance use disorders. Let's turn to the HIV treatment factors. And again, I think this is something new that we haven't thought about. Most of us know these associations, but I caution you when thinking about association and causation. Because something is associated with another, that does not mean it is the cause of it. So association and causation are very different, right? So what we're coming to find out over time is that some of the drugs we thought were really associated and the cause of weight gain really have a neutral effect on weight gain. So that's drugs like TAF, bictegravir, dolutegravir, and CAF. Those that are attenuating are TDF and efavirenz. So once weight gain occurs, right, so you have someone you put on antiretroviral therapy, they gain weight, will switching antiretroviral lead to weight loss? And for a long period of time, we didn't have answers to that. And now we have a series of studies that I think help us guide our counseling for patients, because patients come in and they want to know these answers. Or can we lose weight if we switch? And I think these studies really should serve as a guide for many of you. We're going to go through each individual one now. So here's changes in weight in separate ART switch studies. What you see on the x-axis is the different studies. So SALSA, Tango, Solar, and then the other studies looking at Duravirine. But what you see is the weight change, and that's from baseline to week 48 characterized. So this was a switch to dolutegravir, 3TC, and TDF after the advanced trial participation. So let's take a step back. This was a randomized open label phase 3 non-inferiority trial that was conducted in South Africa. And when you look there, looking at the proportion of individuals with HIV-1 RNA less than 50 copies, they were similar across treatment groups. What were the treatment groups? Well, I'm showing you down there in the slide. So they were dolutegravir with FTC TAF, dolutegravir with FTC TDF, and then efavirenz FTC TDF. So you're using all different kind of regimens. Most of them are modern. Many of us are not using efavirenz anymore. And what we saw with that study is there were higher weight gains on those on the dolutegravir arm, and specifically those with TAF. And it was seen much more in females versus males. And what we noticed in males that you sort of have a plateauing of that weight, but for females, the trajectory is much higher and it kept going. But again, what you saw was about a 8.9 kilogram increase with the DTG plus FTC TAF, 5.8 with DTG FTC TDF, and then 3.3 with efavirenz FTC TDF, and that was at week 92. So that just gives you the background. So what happens when you switch? So here's characterized. So now you're switching to dolutegravir, 3TC, and TDF. And what we see here is a minus 1.6 kilogram weight loss in those who switch from DTG, FTC, TAF. When you look at those on TDF, what you see is there was really not much change. And then again, look what happened when you went from efavirenz to DTG, you started to have that weight gain again. In males, a different story. Very clear here, those on TAF. So again, remember we told you you had that plateau, and then look what happens here. You just sort of see it going down. So there's really not much. However, when you look at green at efavirenz, when they made that switch, you then started to gain weight. But again, I think, so the take-home point for this is, there's something that happens when you go from TDF to TAF and TAF back to TDF. And I think this study really, really summarizes that for you. So the DEFINE study looked at another strategy. So this is switching to a PI-based antiretroviral therapy following weight gain on an INSTI plus TAF. So this was a prospective randomized open label active control phase 4 trial. And what it did was take virologically suppressed adults who had a greater than 10% increase in weight over a 36 months period on those compounds we just talked about. And then they randomized them to either remain on their INSTI plus TAF, that was called the delayed switch arm, or immediately switch to this PI-based regimen. And what we saw at week 24, which was the primary endpoint, is that there was no significant difference in weight change between the arms at week 24. And then the changes were consistent across different subgroups. So those who came in with a higher BMI and sex and race. Finally, we saw some observational data at CROI this year And this was using the OPERA cohort. And they looked at people living with HIV who switched to a doravirine-containing antiretroviral therapy who had viral suppression. And we saw an N of 388. And what you saw was an overall weight loss, about 0.80 kilograms per year. But in women, we saw a 1.67 kilogram weight loss. Most were Black and of perimenopausal or menopausal status. So that was the observational data presented. There is an ongoing trial called the Do It study. It's a multi-center, open-label, randomized trial evaluating percent change in body weight after a switch to doravirine from an INSTI plus TAF-based regimen. And again, you can see the inclusion criteria here. But interesting in this study, you're going to have a switch to doravirine and continuing your TAF, switch to doravirine, switching back to TDF, and then continuing your current regimen, which you have. And that way you'll be able to control. So the study is close to enrollment. And right now we're expecting the study completion to be done around of October of 2024. So stay tuned for later this year, hopefully a late breaker at CROI 2025 in San Francisco.
So let's talk about, after all these data that Bill has shown us, let's talk about guidelines recommendation about weight gain. So the DHHS, they say the significant weight gain may occur with all our regimens, but it appears to be more pronounced with dolutegravir, bictegravir, and TAF. So what we should do is to counsel patients on lifestyle modification and dietary intervention. ARV-associated weight gain should be a factor to consider when initiating or changing ART, particularly in Black women. In Europe, with the INEAC's guidelines, initiation of ART increases weight as part of a return to health phenomenon. So the accent in Europe was put mostly on people who present late. INSI and TAF may induce greater weight gain than other ARTs. So what we should do, and this is similar between the two guidelines, is to consider behavioral intervention, but also to emphasize the importance of behavior goals rather than weight loss goals. So how we counsel people living with HIV on lifestyle modification and non-pharmacologic weight loss options? If I have to talk about weight gain, in the population of people living with HIV that I'm actually following, I think that, there's a sort of two population. In the one that I really worried about are the one that soon after starting treatment, soon it means after a few months, they really come back to me telling that they could not close their trousers anymore. And this really started when they started antiretrovirals. So this is something that I'm worrying about. But if we look at, for example, the number of kilograms that in all studies conducted in high-income countries, people are gaining like 1, maybe 2 in 1 year. I mean, it's very difficult to attribute it to antiretrovirals. So what I do, I really counsel all people living with HIV that come to my ambulatory in lifestyle modification and non-pharmacologic weight loss option, like going on a diet. I'm lucky enough to have also the metabolic clinic in my clinic, so I send them to the nutritionist and also to someone who can counsel them about, for example, the exercise that they have to take. So at first, I think that we should approach the weight gain, unless it's something that was explosive. We should approach it with lifestyle modification and so like exercise and diet. So, and what do you do, Bill?
Yeah, I mean, I do the same, and I do think it's worth spending a few minutes talking about, because for the longest time, when I went back to my charts, I would write down encourage diet and exercise. And we know, what does that mean, right? We are not good as providers. We're not trained how to get people to do the right thing. Some of us are. So I think I've taken a different approach now, and I make sure I I specify what I'm talking about. And I, again, talk to the patient, right? Most patients, if I say, I need you to change your diet, they have a hard time. And I'd rather someone tell me I'm not going to be able to do that. The one thing I will add that I have used a lot more, and it's largely because I'm seeing patients with, increasing weight, obesity, and then comorbidities. So, it starts with high blood pressure, and then it's the diabetes, and then it's the complications that follow of diabetes, hyperlipidemia, and obviously you're waiting for the end result of cardiovascular disease or some catastrophic thing that happens. So I've been a little more proactive with sending people for referral or talking to them initially about bariatric surgery, as an option, because, there's a lot of data now talking about, for people who say, I'm exercising and I'm dieting and I'm not losing weight. And we all think, well, maybe they're not doing that, but they actually are doing it. And they're just at a point where they can't lose all that weight. And so I do think having an option where we think about or consider them for bariatric surgery is important for an evaluation.
But Bill, now that there is semaglutide in, on the market, would you still go for bariatric surgery, or would you first start a pharmacologic weight loss option, especially if they have type 2 diabetes?
No, I agree. I think that's a great question. And I think the problem is right now. So again, let's go back a couple months, and then even right now, I mean, access to these medications is really, it's terrible. We can't get access to them. And even those we get access to, so finally the formularies are starting to come, we can't get the low doses that people need. They only have the higher doses because all the lower doses are not around. And then we've had to call insurance companies and try to see, well, can we start with this drug, even though it's non-formulary, get them titrated up, because you don't want to give someone a higher dose because they're going to get sick and they're going to go off the drug. And I've had this. And also, I think a point to remember is that they don't work for everyone, right? And people do have side effects and stop. And when they stop, they're going to gain the weight back. And so I think you have to have multiple approaches. And I think it's just all about talking. And I think that's the first step. Most of us focus on antiretrovirals and get your vaccines and do this. And are you up to date with your pap smears, anal cancer, all this. And then obesity sort of chugged in there, but really obesity is tied into everything, right? And we're all worried about cardiovascular disease. So I do think it needs to be pushed higher up on our sort of assessment and plan and management, and have it as an option. If we can't get this, maybe we can get a referral to bariatric surgery if the person's interested. So I do think there's lots of ways there that we just need to do a better job at management.
I agree. I agree completely. So, but if we have to switch, what do guidelines recommend? Because for those that I said that had an explosive, really art initiation related weight gain, we should try to switch. The problem is that to date, as the DHHS underlined, it remains unclear whether switching to a non-INSTI-based regimen results in a reversal of weight gain. And it's exactly the same that we have said in the EACS guidelines. So switching from INSTI and or TAF may have a small weight loss effect in overweight, obese people living with HIV. So the evidence are not there yet. Let's wait for the trial. But it's something that we have to take into account, that is not a on-off situation. Once you wait, you gain a lot of weight. Going back is not only a matter of switching antiretrovirals, I think.
Yeah, and I just want to add to that real quick that, I think having been involved in the DEFINE study, the question is what is considered significant, right? And I think we don't really have a definition. So I know for DEFINE, we used 3%. 3% was considered significant. So I think that's where so you can get small weight losses, but I think the question is small enough. So it is an unanswered question that we need to delve into a little more.
Yeah, it was the same in the ADVANCE. They gained 8 kilograms and they lost 1.6. So it's really,
exactly. No, exactly.
You don't go back as a baseline situation. It's
Absolutely.
not a baseline situation. It's not there.
Nope, I totally agree. So let's go back to our case. So I'll just quickly summarize. We've heard this case before. It's a 37-year-old cisgender woman who had started on a co-formulated bictegravir FTC TAF 2 years ago and has experienced a 6-kilogram weight gain that she's attributing to her antiretroviral therapy. So the question is, what can you do, or are there other ways to assist you in making a recommendation for her? So would you consider an antiretroviral change for this case patient? So I think there's a couple ways to approach this, and I'd like to hear what Cristina said. I think if the patient is really adamant that it's the antiretroviral therapy, I could assure her what we know from the data that we have. And again, I think Cristina said, are we then going to start going back to TDF or not? I think what we can do here is just tell the data that we have. But what I've seen people do is switching to drugs that we have data where it says there's no weight gain. So I'm on the fence with this, because I think if the patient's telling you, I think it's related to this, I think it's related to this, and you don't make that change, then you have to worry about, are they going to stop taking the antiretroviral?
I think that, as for any side effects, if you don't trust the person in front of you, they will start to lower their adherence because they really blame the antiretroviral. So you have to change. And then the results are not there or maybe there will be a result because at the same time you say, okay, I switch the regimen, but you should stop drinking alcohol. You should try to exercise. This will help you in losing more weight.
Great. So we're going to turn to the HIV assist. What's your comorbidity? You're concerned for excess weight gain. You put down the co-medications, you put the CART regimen, you list whatever things you have, and you see up there we have a suppressed viral load, a negative HLA-B5701, and then you go on and look. And here what you see is that it gives you a couple options. So it gives you doravirine, right? We know we have data based on that observational data from the OPERA study. And once we get the DO-IT study, we'll hopefully update this in the right direction. But here we have rilpivirine. Notice there with TDF, and then we have efavirenz. So, you may look at these and say, this is not really what I want to do. But I think this at least helps you because this is what you're looking for. Again, so I think the purpose of showing you this is to know that HIV Assist is a great program and comorbidities are a big one to put in there and see what it comes up with.
And it's also updated. So if new evidence come out, the system updates itself. So it's very, very useful in this because maybe you miss the last conference, and so it's updated, and this is important.
Right. So what are the take-home points from this series? So we know weight gain among people living with HIV is multifactorial in nature. Starting ART may lead to weight gain, and that sometimes is due to a return to health. However, when we look at how to approach weight gain, it really should be the same as those without HIV. There really should be nothing different. And when we look at the association of antiretrovirals with weight gain, remember, association does not equal causation, and that's really important to stress. And finally, the reversibility of weight gain by switching ART at this point is really still unclear. So thank you very much for attending this series on weight gain. Go online for more CCO coverage of antiretroviral class, their clinical focus modules, peer perspective videos, and clinical thought commentaries. Thank you very much and have a great day.
Goodbye from me too.
Well, thank you to Dr. Cristina Mussini and Dr. William Short, and thank you to our audience for listening in. Again, to see more of this program and to see the slides from this program, visit the link in the show notes. Thanks again, and we'll see you on the next podcast soon.